Hello, everyone, and welcome to Neuropsychopharmacology's Meet the Author interview series. I'm Dr. Haley Thorpe, an editorial intern with NPP. The Meet the Author series focuses on highlighting the research and achievements of early career and junior investigators recently published in the journal. Today, we're joined by Dr. Helen Collins, first author of an April 2024 NPP publication entitled Rebound Activation of 5-HT Neurons Following SSRI Discontinuation. Dr. Helen Collins was a PhD candidate in the Department of Pharmacology at the University of Oxford in the lab of Dr. Trevor Sharp at the time of this work. Her work uses preclinical models to understand the mechanisms underlying symptoms experienced by those who discontinue SSRI antidepressant medications. So thank you for joining us today, Dr. Collins.
Thank you.
Jumping right into the interview, I was wondering if you could first describe the context and rationale of your study, as well as its core findings for the audience.
Yeah, of course. So thank you very much for having me. It's really exciting to come and talk to you about my work. So SSRI, or antidepressant discontinuation syndrome, is something that happens when people come off their antidepressant treatments. And although it's typically thought to only last a couple of weeks, it can be quite severe in patients and last for many months, and can include symptoms like anxiety and sleep disturbances, but also some weird kind of somatic symptoms like dizziness and nausea. And so although there's a growing clinical awareness that this can happen, there's a really poor understanding of what's going on neurochemically when people come off their antidepressant. And so that was kind of the aim of our study, was to investigate this. And to put that in context, a couple of years ago, we published a behavioral study setting up our model that uses paroxetine, which is a common SSRI antidepressant, and showed that mice discontinuing paroxetine saw an increase in anxiety-like behavior on the elevated plus maze, which is a model that we use for anxiety-like behavior, which we took as evidence of a way of kind of modeling the discontinuation syndrome. And we've since then shown that we also see changes in sleep architecture, again, mimicking the discontinuation syndrome. But previously, we didn't have a very good idea of what was happening to the 5-HT, the serotonin system. And there's some really old data from kind of 30 years ago saying there maybe is a change in 5-HT synthesis, but there was very little out there before then. And so, the rationale of our study was to really probe the key window in the week following discontinuation, and look at the 5-HT system at lots of different levels to kind of work out what's going on, and then relate that to the behavioral effects that we were seeing in the mice. So our main finding was that there was a kind of robust rebound activation of the 5-HT system following discontinuation. So, for example, we saw that there was an increase in 5-HT synthesis and the production of the main metabolite of 5-HT, 5-HIAA, in the 5 days following paroxetine withdrawal, particularly in the midbrain and in the hippocampus. We also did microdialysis to look at extracellular 5-HT, and although the baseline extracellular 5-HT fell following discontinuation, we saw this increased response to stimulation. So we used a polarizing stimuli, and saw that following discontinuation, the neurons appeared more sensitive to stimulation, again, suggesting some kind of rebound activation. And this was supported by CFOS immunohistochemical studies, where again, both 2 and 5 days after discontinuation, we saw this rebound activation of the 5-HT neurons. Again, suggesting this whole system where when you come off an antidepressant, your 5-HT neurons are kind of activated and hyperactive. And finally, we related this to the behavioral effects we saw. So following up basically what we'd done previously, we saw that 2 days after paroxetine discontinuation, there was increased anxiety in these mice, but this had dissipated by 5 days later. So it was kind of a short-lasting effect. But what we take from that is that the neurochemical changes, the effects on the 5-HT system, seem to outlast the behavior we're seeing. So there's clearly something else going on under there that we are obviously still to find out exactly what that is. But that was kind of the main findings of the paper.
I also understand, too, from reading the paper that it's not just paroxetine that is associated with this discontinuation syndrome. It's actually quite frequent or common across different SSRIs. So I was wondering if you could talk about, the prevalence of this syndrome and in what ways you think this work will help with the clinical treatment of depression in the future.
Yeah, absolutely. You've hit up on a really kind of it is controversial, actually. There's been lots of different numbers thrown about as to kind of the rate. So in the paper, I think we cite a study saying that about 50% of people coming off an SSRI will experience the syndrome. There was actually a meta-analysis published about 3 weeks ago saying it's maybe more like 16%, 16 to 20. So I think it's quite difficult to estimate actually how many people are going through this. And I'm sure probably estimates are underestimates. We're not really capturing all of those. but you're right, it is common after different different SSRIs. So paroxetine, the one that we used in our study, is the most problematic. It's the most likely to cause symptoms. Other SNRIs, so these target the noradrenergic system as well, they are also quite problematic. So venlafaxine and duloxetine are also very likely to cause the syndrome. And this is different to kind of some other common SSRIs. So fluoxetine or Prozac is very, very unlikely to cause the syndrome. It's actually probably 100 times less likely than paroxetine to produce these symptoms. And the exact reason for this is a bit unclear. It's probably something to do with half-life. So the shorter the half-life of the drug, the more likely it is you are to get the syndrome. But again, this is kind of not particularly well understood. And so in terms of how that relates to the treatment of patients, now I'm not a medical doctor, so I don't want to make any claims above my station.
Of course.
But I think one of the things that we take away from it is that doctors are really not using paroxetine as much anymore because of these problematic effects it can have afterwards. But I know one approach that is being trialed is the use of fluoxetine to kind of taper people off. So they might be on one SSRI, and when they're ready to start coming off treatment, you might switch them to fluoxetine. So you get a much more kind of protracted washout state, and it takes a bit longer to come out. So you're much less likely to get the symptoms. So yeah, it sounds like different SSRIs can kind of play a role at different points in the treatment journey. But again, that's obviously up to the medical doctors to decide.
Definitely. And I suppose that ties into my next question too, which is,
Mm-hmm.
I'm assuming there's a lot of unanswered questions that are remaining about this work.
Mm-hmm.
So what are the next steps going forward for your line of research?
Yeah, so I think you're absolutely right. There are so many questions, and I think you could spend years and years working on this and really digging into it. Actually, that's what I really liked about it. There were so many new things to kind of explore. So in the short term, one of the things we're working on a manuscript basically further exploring the activation of brain regions following paroxetine discontinuation. So using CFOS immunohistochemistry as we did in this study, but getting a much broader view of the whole brain and looking at anxiety pathways and seeing what's being activated following discontinuation. We're also doing a bit of work trying to work out what the cause of this rebound is. Obviously, we see that 5-HT goes up, but what's actually causing that, and kind of trying to draw parallels to other withdrawal states. So, for example, cocaine withdrawal and amphetamine withdrawal, trying to look at the molecular mechanisms there to see if we can see those effects in our model. So that's all kind of ongoing at the moment. But as you say, there's so many unanswered questions, probably super broad ones as well. So one of the things I think is really interesting is trying to work out why different people experience the syndrome, why it doesn't occur in everyone. Is it just the drug, or are there other kind of predisposing factors that are really not very well understood at all? So I think, yeah, who experiences it, and also if we can prevent it, like, are there tapering strategies that we can use to help reduce the incidence of the syndrome?
Definitely. And I also understand too that now you have finished your PhD and you have started a postdoc. And I was wondering if you could just describe what you've been doing in this postdoc a little bit more and what initiatives you've been working on.
Yeah, absolutely. So I haven't worked on this exact work for a few months now, so it's quite nice to think about it again. But yeah, so I'm doing a postdoc still at the University of Oxford in a separate department, and I'm now looking at basically neuromodulators in the context of Parkinson's disease. So learning lots of new techniques, learning fiber photometry and electrophysiology, lots of cool stuff to basically look at the interaction between neuromodulators in the context of the healthy striatum in rodents, but also what happens when you degenerate dopamine in the Parkinson's state. So I've been doing this about 2 months now, and it's been a steep learning curve, but it's been great. And trying to use all this kind of knowledge about 5-HT, dopamine, acetylcholine that I've got from my PhD and bringing it into my postdoc now.
Those are some pretty advanced techniques too. So
it's been a lot to learn.
Yes, I'm sure there is. Yes. So if people are interested in getting into contact with you about this research that we talked about in your article or your new research, what would be the best way that they could get into contact?
Well, they can absolutely email me. I think my email address is with you, but it's helen.collins@ndcn.ox.ac.uk. I'm also on Twitter, X, at HMCollins1412. Absolutely follow me. I try and post the updates on our work there. And they can also follow me on LinkedIn. It's Helen M. Collins on LinkedIn.
Great. Thank you. That's actually all the time that we have for today, but I would like to thank you so much for joining us to discuss your work. And I encourage that if anybody has questions about what they heard today, to reach out to Dr. Collins directly. You will be able to find links to her contact information that she just described in the video description, as well as in the video itself. And if you are interested in taking part in this series, we encourage listeners to consider submitting to our early career commentary collection or reach out to us on Twitter at NPP Journal with any questions. And we'll see you all in the next interview.
Thanks.